now it's my pleasure to introduce you all to Dr. Doris Wang. So, Dr. Wang, like I said, right now she's joining us from Colorado, but she practices at UCSF. And tell us a little bit about where you practice and how you ended up in neurosurgery, if you don't mind, Dr. Wang.
Yeah, thank you so much, Andrea, for inviting me. And nice to see such a broad group of audience from calling in from all over the country. Yeah, so I'm Doris, and I am a neurosurgeon at UCSF, where I did my medical school, PhD, and neurosurgery training. And I've been always fascinated about the brain, the human brain, how it functions, what happens when circuits go awry, and more importantly, how we can fix it basically since high school. So I've always wanted to become a neurosurgeon, even since high school, and never changed my mind. And now I get to do exactly that. It's such a rewarding field, to take somebody who's been suffering from their diseases for a long time, and through, surgery done safely, really restore a lot of their functions and restore their quality of life. And I can't think of anything more satisfying.
Wonderful. Well, thank you so much for telling us a little bit about yourself. And yeah, we're here to dive in. I believe to guide us through your presentation, you have some slides that you're going to go over.
Absolutely. So I'm sharing my screen, and this is a talk to, introduce everybody to what DBS is for Parkinson's disease, kind of the candidate selection process, and to see if you're qualified for DBS and what the therapy kind of entails. So this is an overview of the talk. I will go over about the general overview for Parkinson's disease, going over treatment functions, and then specifically about DBS, and then how we can learn more. So as this audience probably knows, Parkinson's disease is the second most common movement disorder. It is a progressive degenerative disease caused by degeneration of dopamine producing neurons that's located in a very deep part of the brain called the midbrain. And we actually don't know, despite discovering the disease almost 100 years ago, what causes it. There are probably a variety of genetic and environmental factors that can impact the disease, and approximately affects about 1 million Americans and 10 million people worldwide. And the incidence definitely increases with age. Commonly, it's discovered in patients over 55 of age. So 1% of the people over that age can, have the diagnosis of Parkinson's disease, but it can definitely emerge even early in some sort of rare genetic forms of the disease. In terms of symptoms of Parkinson's disease, a lot of it has been brought to light when famous celebrities like Michael J. Fox and Muhammad Ali presented with some of these symptoms. And what we can see on the outside are mainly the motor symptoms. So people know about the tremor. So shaking, usually in the hands, is common. People can have speech problems, like difficulty getting words out or projecting of their voice. A lot of it's rigidity. So people are very stiff. They have difficulty moving. The movements are often very slowed as well. So difficulty starting movement, it's just not as fluid. And gait, so walking, is a very common problem and symptom of Parkinson's disease. People can have these known as shuffling steps. And then when they turn, they take many, many steps to turn, or they can have freezing of gait where they're unstable and fall. That's known as postural instability. But besides what we can see on the outside, there are also a host of non-motor symptoms, and these can actually emerge and oftentimes emerge even before the motor manifestations come on. This can include decreased sense of smell, depression or mood dysregulation, pain, insomnia, trouble sleeping, and then autonomic dysfunctions like, different changes in blood pressure, bowel or bladder. Constipation is actually one of the very common symptoms of Parkinson's disease. And this is because the dopamine not only regulates the motor symptom, it's involved in multiple other circuits of the brain, including mood regulation and cognitive functions as well. So together, these motor and non-motor symptoms can make the activities of daily living extremely challenging. In terms of treatment options, there's a variety of treatments. None of them, actually reverses the disease course or cures the disease, but they can definitely improve some of these symptoms. So, regular exercise is very well characterized to improve both motor as well as non-motor symptoms. And then typically medication is the first line of treatment. So these include levodopa, which is called L-DOPA therapy, is one of the first medications given. And there are other variety of medications that can either slow down the breakdown of dopamine in the brain or increase the kind of the available dopamine in the brain. And then we talk about, once medication kind of fails, and this is kind of the focus of the talk today, then we dive into more invasive therapies. And the options include neurosurgery. So ablative surgeries where we basically lesion, create a hole or burn a hole in the brain in a very precisely located area of the brain can improve some of the symptoms. But DBS, which is a focus, what I'll be talking about today, I would say is the gold standard after medication in terms of treating a lot of the motor symptoms of Parkinson's disease. And it uses a battery-powered electrical device to kind of pace the brain. You can think of it as a brain pacemaker that restores dysfunctional neural circuits to more normal functioning. And then finally, neurorehabilitation that can occur anytime along the the treatment course, such as physiotherapy, occupational therapy, speech and language therapy. They can often be used in conjunction and provides assistance with motor and non-motor symptoms. So what is DBS? DBS is a neurosurgical procedure, which is what the focus of my practice is, which involves, implanting a brain electrode. So these are very thin wires, about the size of a spaghetti, really, really thin, precisely in, a few of the brain targets. And then these wires are connected to a lead extender. So just a connection wire that runs under the skin. And that's connected to a battery, which usually is located, implanted in the chest area. So everything is implanted underneath, no exposed wires or anything. And together, this system provides the power needed to, again, kind of restore the brain rhythm to its more normal functions. So as I mentioned before, medication is a great first line of treatment. So when should somebody start considering additional neurosurgical procedures to help manage their Parkinson's symptoms? And, this picture kind of tells you part of the story. So earlier in the disease course, a patient can take an L-DOPA dose, so indicated by this blue circle here. And the medication can last, pretty much throughout the day, and patients have really good on time. So on time means, pretty much symptom free. So it can really reduce a lot of their symptoms, and not a lot of their, friends would even can tell somebody has early Parkinson's disease. But over time, basically these on times provided by medication shorten. So the therapeutic window shortens over time. So what happens is in the moderate disease states, patients have to take medication more and more often. They don't last as long. And then, in between doses, people feel more symptomatic. And then in the more advanced stages, so now we're getting into kind of dose failure and failure of medication to adequately control someone's symptoms. So they are basically, developing dyskinesia, which is too much involuntary movement and is associated with a side effect of L-DOPA therapy. So when you take your medication, you get, it takes a while for medication to kick in. And sometimes, even taking medication is not associated with on state. So you can have dose failures. And then once the medication finally kicks in, patients has on time, so they're moving better, but then they're kind of riddled by dyskinesia, so the side effect of too much medication. And then in terms of timing of when the medication wears off, it becomes less predictable. So this is kind of the more advanced PD state. So when somebody basically develops these motor fluctuations, with the optimal levodopa treatment in terms of changing formulations and different types of medication, is a really good time to start considering additional therapy. So the window of opportunity for DBS is not wide. Usually we don't offer it to really mild symptoms just because the risk of surgery is probably not worth it. And if, symptoms are really well controlled with a couple doses of medication a day. But once patients develop fluctuations, as soon as they fluctuate, we know that they're headed down the path in which medication is going to stop giving patients adequate control of their symptoms, and it's only going to get worse from there. So that's actually a really good time to consider DBS therapy. Because once the symptoms, continue to progress, the things that would prevent a patient from getting DBS is if they have really, really advanced or end-stage Parkinson's disease. So when they're riddled not only by the motor symptoms, they become unresponsive to medication, but also have, cognitive problems or dementia. That's often too late to get DBS. So you kind of really want to capture the sweet timing, the window of opportunity when you start developing fluctuations to get started in the evaluation process. And one thing I want to drive home, this is if you don't take away any points from my presentation, is that DBS should not be used as a last resort. You shouldn't have, tried every single thing under the sun before, there's no other thing they can think of to be referred for DBS surgery. So really, moderate symptom is a good time to consider or ask about referring process. And patients who are good candidates are those, who basically have idiopathic Parkinson's. So just basically meaning your standard bread and butter variety, not Parkinson plus syndromes or, Parkinson's caused by, say, stroke. And that you should, the optimal patient should have response to medication. And again, it's on-off fluctuations that are limiting their quality of life. And again, if patients have dementia or have, serious medical conditions that prevent surgery from being performed safely or has progressed to late stage Parkinson's disease, then it's too late to be evaluated. And basically, what does DBS, what can it help with, It only in the current state, it only really helps with the motor symptoms of Parkinson's symptoms. So that include tremor reduction. And the tremor reduction, is actually one of the great benefits of DBS. And this is one symptom. You don't actually need to show medication responsiveness to be evaluated for DBS. And it can reduce the rigidity, stiffness, the slowness of movement. And if you have, even some gait problems like shuffling gait, dystonia, contraction, of muscles, causing muscle cramps, as long as these symptoms respond to medication, then there's a good chance that DBS can help with that. And it can possibly reduce the medication dosage. It still works best with medication because DBS doesn't replace dopamine in your brain. So we still need some medication. But instead of, kind of fluctuating up and down, it just kind of gives you more on time overall. And it can really improve quality of life. But of course, it's a surgical procedure. And, it is a big deal, I realize, when people need to, undergo brain surgery for this therapy. But overall, this surgery is very safe. And I would say it's, pretty minimally invasive as far as neurosurgical procedures are concerned. Again, I'm just, drilling small holes about the size of a quarter on the skull and then implanting this very thin, 1.5 millimeter diameter electrode in the brain. But the main risk of surgery is risk of infection. So that happens about 2 to 5%. Just from poor wound healing, or sometimes people just get unlucky. Risk of actually causing a major hemorrhage in the brain is very low. I would say it's less than 1 in 200, so about 0.5%. Changes in speech, mood, or vision, it can happen with stimulation. If you turn on stimulation high enough, you are going to have off-target effects and side effects. So, it may happen, but as I will go into a little bit later, I think with the newer technology provided by DBS devices, we can really improve or lessen these side effects. And then seizure, stroke, again, those are very, very uncommon. And then in terms of, data, so there's, clear class 1, that's the highest level of evidence that DBS can really improve Parkinson's patients' quality of life. There's been several, really well done randomized control studies out there that basically, have patients do best medical therapy versus DBS therapy, and DBS is clearly superior. And then this is a study that was done recently. This was sponsored by the Boston Scientific company, where it's a first multi-center prospective randomized sham-controlled double-blind study. So it's a mouthful, and what it means basically, it's recruited 160 subjects from 23 sites throughout the US, and basically all patients received DBS surgery. And this is with the old, DBS system. And then some patients were randomized to not get any stimulation, and then some people got the stimulation needed. And basically, the bottom line is, even at 1 year, patients receive an additional increase of 6 hours of on time during the day without troublesome dyskinesia. So which is a huge amount of benefit, thinking of maybe 12 plus 18 hours of awake hours. That's increased a third of the time in which patients can move better, have less motor symptoms from their Parkinson's disease. All right, so now let's talk about, kind of the evaluation process. So once you're diagnosed, you definitely should see a neurologist who can, prescribe the medications needed to control your symptoms. And then once, if you have access to instead of a general neurologist, a movement disorder specialist neurologist, these are, neurologists who have additional training in Parkinson's disease, they might be better in terms of directing you, changing the medication. And then once you develop the fluctuations, a really good time to ask your doctors for referral to see a neurosurgeon or to a center to see whether you qualify for DBS. And so that's one kind of where I step in, where a tertiary referral center. So we get referral from community movement disorder neurologists or general neurologists when they think patients are ready for DBS. And we have our own, many movement disorder neurologists within our team. So we do they see the patient and I see a patient. And then once a patient seems to be appropriate, then we pursue the full workup. And at our center, every place is slightly different, but usually people do a multidisciplinary approach to determine candidacy for DBS. So the things we do at UCSF include first getting a brain MRI, again, to rule out any mass lesions, any things that could cause, non-standard secondary Parkinsonism. And then we have a neuropsychologist evaluate the patient, again, to look for, mood dysregulation, cognitive deficits, just to make sure, they can tolerate the surgery, and then also the programming involved with, having the device. The movement disorder neurologists also perform an on-off testing. So they will have patient withhold their Parkinson's medication for about 12 hours, do evaluation, physical exam to see how bad their symptoms are, and then have the patient take their regular dose to see which of those symptoms improve with medication. And usually we're looking for at least 25% improvement in their symptoms before we refer them for surgery. Tremor is, again, one of the things that doesn't have to respond to medication to qualify for surgery. And then finally, once those evaluations are done, we get together as a group, decide whether the patient seems to be a good candidate, which method, which target we pick, and which device. And then they see me for lead implantation surgery. So the surgical part, I think, once we select a good patient, it's kind of the easier part. So, I can do the surgery either with patient partially awake in the OR, or I do it in MRI suite under complete image guidance and where patients under general anesthesia. And then, so that's a brainly part. And then we implant the stimulator, the rest of the implant components. And then once patients are healed from surgery, usually, a couple weeks, then that's where their journey that's when we turn on the device and see what the device can do. And the programming and optimization is usually done by the movement disorder neurologist and our wonderful team of nurse practitioners and nurses who have extensive background in DBS device programming. Okay, and now I'll talk about specifically about some of the things that are possible and the novel technological developments that's possible with Boston Scientific devices. So as you can see, there are a variety of batteries and hardware, and it's really challenging to figure out which one's best for you. So there are a few things with Boston Scientific that makes programming a little bit easier. So, as I mentioned, so after this whole process, programming is the most important part. And every brain is different. And, we kind of have an idea of where to start with programming. But if you can think about it, there's multiple amounts of energy we can deliver to your brain. We can change the pulse width of each stimulation, the frequency of stimulation, the contact. So there are, thousands of options, if not more, available to stimulate the brain. So optimization can take a long time. So that's why I think we're developing all these additional tools that can reach the optimized setting a lot sooner in patients. So the two most commonly implanted targets for DBS in the brain include the STN subthalamic nucleus. Target is a globus pallidus interna GPI. And basically, as I mentioned, we kind of determine which target we think will help you based on your symptoms and your neuropsych testing. And the thing is, with STN, this target is really small. It's the size of an almond. So, and you only want to stimulate a portion of these structures. As I mentioned before, if we stimulate, its very high real estate neighbors, we can actually cause unwanted side effects with stimulation. So precisely control the stimulation and which brain area it goes to is extremely important for the success of DBS therapy. And so here's an animation showing, an STN. So this is kind of blue area. This is one of their directional leads that's implanted in the area or near it. And then these are yellow fibers that can control your movement. And that's the area that we don't want to stimulate because stimulation of that area can cause slurred speech or unwanted contractions. And of course, while I try to place a lead right in the middle of the subthalamic nucleus, every patient's anatomy is slightly different. And there are just inherent errors, with the surgical procedure. So the lead may not end up exactly where I want it to. And even if it's off by 1 millimeter, it can cause some of these unwanted side effects. So the idea is now with these segmented contacts, we can steer the current to precisely control where the stimulation electricity is going towards the nucleus and away from areas that we don't want to stimulate. And this is a kind of interesting comparison or analogy, I suppose. So, your brain has, imagine it as a forest, has many trees, and then basically the sweet spot of stimulation is kind of like trying to find a treasure in this forest. And, traditionally, how the programming works is that basically the programmer will just go through each contact, turn it up slowly, and then test the patients for improvement in their symptom or side effects, and then, go through it systematically. So as I mentioned before, it's very time consuming and it's kind of subjective because, patients can be fatigued and it all just depends on the examiner. So it's like going on a treasure hunt in the dark with no map. But Boston Scientific has the image guided programming, which I'll show you in a little bit. It's kind of giving more clarity, it allows us to visualize where the lead is in relation to the nuclei of interest. So it gives us a better guidance. Of course, it may not be the most, accurate, but still gives us an idea of where we should constantly focus our stimulation on. So the hope is that we can reach the optimal setting a lot faster. And, the map and the treasure, again, analogies, the map would be the brain and the specific structures that we're trying to stimulate. So it kind of streamlines this process. And instead of using, a common map, we're using personalized images from each patient, incorporate into the programming session. So not sure if I have slides about it, but currently what our center uses is basically we import the patient's own MRI and image into the programming tablet. So when the clinician is ready to program the device, we have a model of the lead of where it is relative to these structures, and also the directionality. And then, pretty soon you can see this, for instance, this lead is really well placed. We're trying to stimulate the ST and the green, but probably we don't want the current to go more towards the middle where the right nucleus is. So then we can really focus stimulation to stimulate this contact lead, on the lateral contacts to optimize stimulation. So again, using this powerful tool gives us the clinicians a better guidance about which contact to use in order to reach optimal setting. And then just in terms of what the devices that Boston Scientific provides, they have a variety of non-rechargeable batteries, and then also a couple of rechargeable options. The non-rechargeable battery, once it's implanted, just like your standard, AAA batteries, once the battery goes down or, depletes, then you will need a outpatient procedure. It's pretty quick, but still it's a surgery to, remove the device and replace it with a new one. The rechargeable battery lasts 15 years, but it does require more maintenance. So the advantages of a non-rechargeable battery is the idea is, once you reach optimal setting, you can kind of forget about it, having to, maintain the device. So it's kind of simplify someone's life. And depending on your usage, it can last anywhere, I would say, from 3 to 5 years is average. Then you have to undergo replacement surgery. The rechargeable battery, the good things is, lasts 15 years. But then just like, our smartphone, smartwatches, it does require more maintenance. So patients do need to recharge the device. It's, induced by, it's recharged wirelessly. And depending on usage, some people charge it for an hour or two, once a week. Some people do it for 10 minutes every other day. So depends on your lifestyle, but you have to kind of maintain it to make sure your battery has enough juice to provide therapy. Yep, so these are kind of the, advantages and disadvantages. And because a rechargeable battery doesn't have to hold enough, power to last many years, it is much smaller than a non-rechargeable device. And all these devices are actually still MRI conditional, meaning that you can still bring MRIs even with your device. So it's pretty nice, it doesn't preclude you from getting MRI in other parts of your body. And then the leads, currently there are 2 types of leads out on market. So these are kind of the 8 contact, each lead, each contact is, spherical, so they're in ring mode. But then you also have the Cartesian directional lead in which, the middle 2 contacts are segmented. So this allows us to direct current towards, allows us to steer the current where we want it to go. And then in terms of the patient accessories, as I mentioned, the charging system allows the patient to interact with your device wirelessly. So basically you have this external battery pack. As long as you keep that battery charged, you just place in a kind of a sleeve around your neck, and then you can be carrying out normal activities, and it would charge your device wirelessly and passively. Each patient has also a remote to your stimulator, allows you to check the battery level. You can, with your clinician's blessing and also, setting the level, you can also adjust your stimulation. So usually we give, a range for patient. So if they're taking their medication, they feel they don't need too much stimulation, they can lower it. Same thing, if they're in between doses or feeling more wearing off, then they can increase stimulation. And then also allows you to turn your stimulation on or off. So some other things is that, there are multiple devices out there. There are adapters. So, if you have a different system of brain lead implanted, Boston does have a few adapter systems that can, allow you to connect your brain lead from another company to their battery. And it also receive MR conditionality, so you can still get MRI even if you have a mixed system. So, again, it's a very nicely streamlined system with Boston Scientific. Now we have image guided programming, has the most stimulation options. So allows, the programmer to decide exactly what % of the current is going through each one of the contacts. And there's just a lot of flexibility in terms of how and where to stimulate for your brain. And then 5 nicely contoured batteries, which are small in size, pretty ergonomic. It has MR conditionality, and then these very easy to use accessories for the patient to control their device. And here are some resources from the Boston Scientific Company. If you have any questions about DBS or the device, just go to their website and learn more. And then there are also patient ambassadors you can speak with. And so that's it. And I would like to open this up for questions.
Wonderful, thank you. And yeah, there actually have been a lot of questions coming in. I'll go through and maybe group some and order them. So there are a couple of questions about exercise with DBS and specifically swimming with DBS.
That's a very good question. So yes, the idea is you can exercise, carry out all your normal activities after DBS. Once you're healed and you get okay from the neurosurgeon, you can, go swimming. We have patients who've gone like deep sea diving actually after DBS. So it's totally fine. But I think one caveat, you might have read this in the news, is that some people after DBS, they kind of forget or, couldn't perform coordinated complex motor sequence of movements as well. Again, I don't think that's everybody. I definitely have patients who can still swim just as well after DBS is turned on. But I would just say take it easy and slow at first and make sure, you're in a pool with people watching you, just in case you're having some of these kind of side effects in terms of sequencing movements.
Sounds good. And let's see. So question about, so you covered, some of the symptoms that DBS most helps with. What about sleep, energy, and mood?
That's a really great question. There's no definitive evidence that it can help, but anecdotally, it can help. And the thing is, DBS sometimes affects those things, the non-motor symptoms. It's kind of unpredictable which way it goes. So I've certainly had patients who have, kind of depression and mood issues before DBS. And we're really careful, in terms of selecting brain targets for these patients. Kind of depends on what's causing the mood problem, because some people, they say they get depressed when they can't move as well. So by indirectly helping their motor symptoms, their mood improves. But also we know that people with, major depression, one of the targets of ST and DBS, can actually, really exacerbate the mood symptoms, can make them kind of bipolar, really elevate, kind of go into almost like a hypomanic or full-on manic episode, or they can really exacerbate their depression. So, it's unpredictable right now which way your mood will go with DBS. In terms of energy, again, kind of depends, right? If the low energy is from kind of wearing off with the medication, then DBS should help with that. But also I have patients who after DBS, they feel like more fatigued. And I think that's more transient, probably more from just recovering from brain surgery rather than, because stimulation side effects. And then sleep, I would say DBS probably doesn't help with sleep, or, of course, there are patients who say they either sleep better or worse after DBS. There's no clear association, but we're kind of working on the non-motor symptoms right now.
And unlike, if you're on medication when you're asleep, you're obviously not able to take medication. If you have DBS, does it keep working while you are asleep?
Yes, that's idea. So yeah, it's on continuously. So basically, most people use, require high frequency stimulations, like around 130 to 180 hertz. And yes, it continues to work while you are asleep. So that's why, DBS, again, it kind of provides a baseline. So you don't need as medication, or you don't need medication maybe quite as often or as much.
Okay. And let's see, Susan asked, she said they're always talking the jargon, STN or GPI. You covered STN, and that was a great animation as well. But she wondered, what about GPI? Could you just give a
Yeah, so in terms of motor symptom improvement, there are many published studies. They do both equally well. I would say, at least kind of how I approach STN versus GPI is based on the patient's overall profile. The advantage of STN DBS is that it can reduce medication more. In terms of, a percentage of symptom improvement, it doesn't show, a drastic difference from GPI. But the nice thing is you can really reduce medication. But then the side effects, on maybe cognition and mood, especially, for patients with pre-existing cognitive or mood issues, is greater. So it has more side effects on those domains. So if you're a young person or younger person without, a lot of cognitive or neuropsychiatric comorbidities, then usually we pick STN. GPI is just a larger target. So it's nicer for patients who might be more older, frail, have some mild cognitive impairments. So it's a little bit more forgiving. And then some more subtle difficulties if there are patients who even with the slightest dose of dopamine can really get dyskinetic, then STN stimulation is a little hard to control because stimulation in STN itself can cause dyskinesia if you're just a little bit off balance with your dopamine. So for people who have a lot of dyskinesia, then GPI might be slightly more favorable.
And so there's battery choice. There's which device company to use. There's STN, GPI. There's a lot. It's not just DBS, yes or no. For people considering this, how many decisions are they going to actually be faced with? Or is it more the clinical team that will do all of that decision work for them?
In terms of, yeah, that's a great question. So good news is we have a lot of options and good options now. It can make navigating through this space really challenging. And, at our center, we primarily work with Boston Scientific as well as Medtronic, but there's also Abbott out there, which I just personally don't have a lot of experience with. So there are some subtle differences. I think baseline, getting a device in the right location, you're going to have improvement. There are just some subtle differences between the devices and what therapy can provide. So with Boston, you have a lot more, I guess, probably a little bit more flexibility in terms of, programming options. You can fractionate the current, you can do blocking off the segmented contacts. Medtronic, with their newer system, they have directional leads as well. You can have a lot more control. And then I think they do have, sensing function. So, something like adaptive or closed loop DBS, where you're using brain signals to control stimulation down the line. That is a possibility with Medtronic device in the future. And then Abbott, some of the other one thing it does offer is remote programming. So for people who live further away from a provider, I think there's a way you can, Zoom with your neurologist and they can program your device. Instead of having coming in person to adjust it, they can do it remotely. So there are definite subtle differences, and we actually kind of leave it up to the patient. How I approach it is I present them with the options and then let them decide which one they want.
Okay. And you mentioned closed loop. There were two questions about a closed loop system, both whether the Boston Scientific device can do closed loop or how far away is a true closed loop system. So for some of us who, could you start by refreshing, what does closed loop mean before you answer those?
Yeah, absolutely. So current DBS technology works by just continuous stimulation. So it's on, once your clinician sets a setting, you kind of stay at that setting. We can give you maybe a few, like 3 or 4 different programs that you can switch between depending on your symptom. But the thing is, all Parkinson's patients know is that your symptoms fluctuate throughout the day, depending on your medication states. So the idea is, beyond what DBS is able to give, to even further improve or personalize therapy based on your own brain signals. So closed loop DBS is kind of a smart DBS, kind of like the defibrillator. So when you have the heart monitor, when you detect an abnormal rhythm, that's when they send the shock. They don't shock it continuously. So that's kind of the idea, is that, we can change stimulation pattern or amplitude based on what your brain is telling or what your brain kind of needs based on your motor symptoms. So in terms of closed loop technology based on your brain activity, I don't think the Boston system right now in its current state does not provide that. Medtronic, it has that sensing capability, but right now there are clinical trials testing whether the signal that we can detect, like how to feed that back. So they're working on the second part. In terms of mass producing it, it's probably within the next few years. Does that answer all the questions about closed loop?
I think it does, yeah. And that seems to be the hot buzz topic that people have been interested in. Maybe there's been some recent news releases, or at MDS, maybe that's been
Yes.
a topic of interest. So let's see. Okay. Are there types of PD patients that are harder to program who would benefit from the treasure map guided imaging stuff?
Um, yeah, I think, yes. The short answer is yes. So if we can have, your a good image of, I guess, your anatomy prior to DBS, a good MRI map, and then your electrode location, then using that, image guidance, then we can try some additional new parameters to see whether we can get away from the side effects. But again, it kind of depends on, the location. So if the lead is truly not in the right target, then it's going to be hard to make those changes. So I think, what the image guided programming and also, with a directional system really improved is, when I try to place a lead, unless I'm more than 2 millimeters off of target, it's actually surgically really, really challenging to make these, sub-millimeter changes in the OR. So I think that's, again, a lead has to be well placed. So we try to be as accurate as possible. But then what these directional contacts can give us is additional freedom to, even if we're off by 0.5 millimeter, really optimize this therapeutic window that way.
Such small, millimeters and sub-millimeters. That's crazy. You work on a very precise scale in your work.
Definitely.
Let's see. So, questions about if there are adverse reactions to speech and swallowing post DBS, what can be done to correct those issues? I don't know if you, as the surgeon, would know the answer, but maybe you do.
Yeah, so I think, when people have experienced side effects, I think also somebody wrote, like, with after DBS, like the speech was really bad. We have to see whether it's truly stimulation induced or is it progression of disease or something else going on. So I think the first thing I would test is, turn off your stimulation to see and give a period of washout, just, waiting sometimes even days to see what symptoms, improve or doesn't. And if we have confidence that, these issues are caused by actual stimulation, then the next thing is to see, I would do image to, again, make sure that the lead is in a relatively good location. And then after that, it would just be programming. So can we program around the side effects or find settings and things that we can, avoid the side effects or lessen them?
Mhm.
And then one thing, there's always a backup, if I guess if you're trying to speak where stimulation really affects your speech, if you're say, giving a talk, then turn off your stimulation.
Mhm. And a similar question, if DBS negatively affects mood, what is the treatment for that? Is that the same thing where the programming could be the answer?
Um, with mood is really challenging. You know, especially in the STN, where it's smaller areas, so all the circuits are not as well segregated. So, spread of the current can cause mood issues. And the mood, um, it's hard to pinpoint if like mood is really from stimulation. But again, if it is determined that DBS is negatively impacting mood, I would say try other things like medication therapy, so antidepressants and such. And in fact, I should mention that a lot of our patients, actually, even before DBS gets implanted, if on our evaluation we find significant mood lability, for instance, like fluctuating mood with the medication or significant concerns about anxiety, depression, we actually refer a patient to a psychiatrist so they can follow them very closely after DBS is implanted. So then they can adjust their medications as needed.
Okay, good. And someone wondered, if I decide I want to get DBS, how long is the lead time? So with the pre-testing and the scheduling, how far out people have to plan their lives?
Depends on the center. I would say, probably on the order of like 6 months. Once you see, again, depends on the practice setting and where you are. So I can only speak for UCSF, our center. So, once you, I guess, gets referred, takes, anywhere from like 1 to 2 months to see a neurosurgeon and movement disorder neurologist. And then once we think you're a candidate, then you need the on-off testing, neuropsych testing, which takes, 2 to 3 months to schedule. And then once that's decided, then you have to wait for surgery. So conservatively, I would say like probably about 6 months.
Okay. And we have one attendee who recently was implanted. So what is the post surgery? What does that, time frame and window look like?
Yes. So we don't, at least at our center, we don't usually program patients turn on your device right away, just because the act of inserting a lead can cause microlesion effects, so brain swelling, which makes programming a little more challenging and inaccurate. So we wait usually 10 to 14 days once we think the swelling goes down to turn on your device. And then during the middle, you basically continue, your medication normally. I tell patients to resume all their normal activities except just, keeping their incision clean. So that's a key period in which wound care is extremely important in preventing infections. So then once you're healed, your sutures are out, you get programmed, then you can carry on normal activities.
And how long does the programming uh, trial and error getting it right? Is there an average, at least some rough average that you can share?
Well, now with the image guidance, there's actually a published report, I think in Frontiers in Neuroscience, that people are able to reach it a lot faster within, weeks or even within the first session. But I would say, average probably 2 to 3 months
Okay.
before, it can take as long as, 6 months or even a year. But I would say most of our patients tend to receive a version of their final programming fairly early on.
Okay. And let's see, we're covering most of the questions. Okay, here's some additional ones from Bernard. If you have Medtronic's current system, Could you get closed loop via software upgrade, or would you have to have a whole new implant when that is available?
Yeah, if you have the current Percept PC, then you just need a software upgrade. So all the closed loop adaptive functions are actually embedded. It's just not unlocked for until it's approved by the FDA.
Okay. And then a question about MRI guided versus the alternative. Could you talk a little bit about that?
Yeah, so there are many different ways to put in an electrode, and then there's no gold standard, but I would say depends on the surgeon's comfort and experience, the technique, and then also patient's comfort. I think those are the most important factors in determining the optimal method. So for instance, for awake surgery, obviously I need patient to participate. And so for somebody with a lot of anxiety, and also a really hard time with being off of medication, because for awake surgery, we kind of turn on your stimulation in the OR, and we do tell people to be off of their medication. So if they're really uncomfortable, just can't focus on, their symptom, then it kind of does, being awake doesn't help. So, for those cases, yeah, I kind of discuss this with the patient, but I would probably guide them towards a sleep procedure in which they don't need to stop taking their Parkinson's medication. They're under general anesthesia, and our imaging techniques are really good. In terms of actually pure accuracy, this paper is just came out in Journal of Neurosurgery, or actually Neurosurgery. Our MRI targeting accuracy is better than awake. But in terms of clinical outcome, it doesn't matter as much. And then just from my own experience, with some targets like STN, I've, implanted leads awake and got the lead to be exactly where I want to be. But then when I turn on stimulation, I see side effects. And just, again, everybody's brain wiring is slightly different. In those cases, I was very glad I did it awake, because based on the pure image guided, implantation, I probably would have just left the lead there. So I think there are, always exceptions, and I think that's super rare to have a case like that. But it really just depends on patient comfort, and I'm comfortable, performing either surgery because that's, how I was trained. But I think having patient experience, it's really important.
How many hours for awake versus asleep surgery?
Yeah, so in terms of absolute time, awake is probably, it's going to be a little bit longer because we do all the testing. And then on average, I would say awake surgery for bilateral DBS, 2 sides, is probably like about 4 hours. Again, a lot of it's set up. And then for MRI, bilateral surgery, it's about, 2 to 2.5 hours, the opening time. But in terms of absolute OR time, like anesthesia and such, it's about the same.
Okay. Some fun questions about traveling and leads and batteries in the airport scanner.
And yeah, so they're safe. These devices are tested under very high strength magnets, so you can definitely go through security. We just give you a card, and then you just show them that you have an implant.
Mm-hmm. And then Greg wants to know if he would have to shave his head.
Yes, I do cut hair, especially near the incision, just because your hair is really, it's a nidus for infection. I could do minimal head shaves and hair sparing, so then, preserve a lot of it. But because of the incisions, it's usually one for each side on top of the head, and then one kind of where the lead extension goes. The haircut is kind of funny. So some of my patients just opt to get full head shave.
Including your female patients?
Yes. So they can grow back together, all even.
Yes. Interesting. Well, thank you so much. So that was a real rapid fire Q&A too, and you handled all of those questions. So bravo both to the audience for coming up with some good ones, and thanks, Dr. Wang, for being able to, answer things, and everything from, haircuts to future technology and everything in between. But that does wrap our time today. We have a ton of resources about DBS on pmdalliance.org. And as I mentioned, the recording of today's session will be uploaded. Give us a couple days to get that up. So you'll be able to refer back to that or share it with friends. But we always like to close with a gratitude wave. I invite everyone who has their camera off to turn it on and get some a quick moment of eye contact as we say thank you to Dr. Wang for teaching us, and such a pleasure to learn alongside all of you. So thank you again, Dr. Wang.
Thank you so much for having me.